First, I would like to introduce myself. I am Dr. Alattas from Saudi Arabia. I am from Najran University, which is located mostly in the south region of Saudi Arabia, which occupied around 20,000 students there. This is the sky view of my dental school, and this is front, and this is from behind, as you can see. And this is the lobby of my dental college. This is the Phantom Labs. Today, it is my opportunity that I will present my cases of diagnosis and treatment of mandibular, a second premolar with the 3 root canals as a case report. We know that the success of endodontic treatment depends upon through debridement and complete obturation of the entire root canal system. If we want to get a good root canal system, that we have to do a good cleaning and shaping and full obturation of 3-dimensional of the root canal system. This is not enough. Also, we have to know all the variation of the all root canal all the variation of the canal it could be suspected in the tooth. All the tooth we have to be know to get a successful endodontic treatment. According to Wine, the major causes of endodontic failure are incorrect canal instrumentation, incomplete obturation, and untreated major canals. Also, according to Cohen and Braun in 2002, failure to recognize the presence of additional canal may result in unsuccessful treatment and may be the origin of acute flare-up during and after treatment. This is typically of my cases that I will present today. This is typically that incomplete treatment of root canal system, and the missed canal may will lead a failure of root canal system and will lead flare-up later on. Anatomical variation of mandibular second premolar have been documented in endodontic literature. As we can see in this table will show most of the study that is done for incidence number of canal of mandibular second premolar. Most of the study with a different technique, with a different country, the most of it is a 0, except in Zelchi and Dawson in 1973 and Al Gouda in 2009 in Jordan, they reported it's only 0.4 and 1 0.5, which is mean it is very rare case it could be having that a second lower premolar, that it could be with a 3rd canal. Not only that, also there is many cases reported mention of a second premolar with 3 canals. It could be also with 4 canals or with 5th canal. Like Adib in 1982, he reported the case with 3 canals, and Al Fawzan from Saudi Arabia, he reported 1 case with a 4th canal. That means we have to be careful when we are treating the second lower premolar. It could be suspected that it be have a 3rd canal or 4th canal even too. My case is report today. There is one patient came to my clinic. It is 20 years old, Saudi male, with no medical problem. He attends to my clinic. He complaining of pain, right lower posterior region. This case, he have a history of endodontic treatment in tooth number 4-5. In the American, it is 29. As a general practitioner, 1 year previously, he did a root canal treatment. Clinical examination for that tooth, we found the tooth with amalgam filling, and it was tender to percussion and painful of palpation. It's very important. During this case, we have to be very careful to read in the radiograph pre the treatment of the patient. Because as we can see here, there is 1 incomplete root canal treatment with periapical, I don't know, it's clear for you there, I don't know, with periapical region. Other things that once there is any density changing in the tooth root, that you have suspected there is another canal, which is clear in my cases. Diagnosis for this case is incomplete root canal treatment with acute exacerbation of chronic periodontitis. My planning for this case, it will be non-surgical endodontics was planned for tooth 4, 5, or 29, over 2 visits with calcium hydroxide as inter-appointment intercanal medicament. As we know, the first step that for treatment this patient, we have to do a local anesthesia and we have to do a rubber dam. In this case, we have to modify our outline axis to find any extra canal we have to suspect, especially in this case. At the beginning, we did axis cavity modified, and we remove the old filling of root canal treatment, and we widening the orifice with Gates gliding to explore all the canal we suspected in the pulp floor. After that, it's really important in this case, or any case, you have to take your time to explore all the pulp floor. For any extra canal, it could be fine. I use in this case, loops is 3.5. It was surprised that it will be a third canal to be suspected. In the radiograph, you see it's suspected only 2 canals. But it's also important to very careful examination of the pulp floor using this new technology for identifying any extra canal to get a success root canal treatment. In my cases here, I found a third canal, 3 canals, which one? It is in the distal, 2 in the distal, 1 in the mesial. In the distal it is 2 buccal, dustolingual, and 1 in the mesial. This is just imagination that of this tooth was extracted for orthodontic reason. It is the first premolar, that it could be 1 mesial and 2 in the distal, 1 in the buccal, and 1 in the lingua. In the X-ray, you couldn't see this by parallel technique unless you have to do a shift. Most of the cases reported regarding the location of the canals, it is 2 in the buccal and 1 in the lingual. Except one case is did by DeMori and Garrison in 2005. They found the same my cases is 2 in the distal, 1 in the buccal, 1 in the lingual, and 1 in the mesial. As we can see here, this is the mesial canal, this is the distobuccal, and the other is the distolingual. What is mean, not only it is rare cases for 3 canals, but also it is rare for the location of the canals too. Regarding the Fortucci classification, it will be number 9 because CERT added a 14 or 15 classification to his classification. After that, as a normal, as we do, we have to take our working length and confirm or radiograph apex locator, and we did clinical shaping with crown down technique. I use here a brow taper up to F2 with sodium boride irrigation. After that, I dry the canals with sterile paper point, calcium hydroxide, which applied internal canal medicament for 2 weeks, and the access cavity was sealed with iron for 2 weeks. After 2 weeks, the patient came to my clinic. All the symptoms have subsided. After that, we removed the temporary filling. We did canal was dried. Canal was dried with paper point. After that, I did my obturation with F2 gutta percha and AH20 sealer. After 1 week, after 2 weeks, after 1 week, the patient came. After 1 week, the patient came to my clinic to do his final restoration. This is the X-ray with a temporary filling, as we can see here, with a full 3-dimensional obturation of root canal system. And this is after of amalgam filling, which is the final filling for that. And we referred him to the prosthetic department to do a crown for him. In discussion, mandibular second premolar is one of the most difficult teeth for endodontic treatment because of the variation in intercanal morphology, extra canals, and apical delta and lateral canal. It could be found in that case, especially lower second premolar. Variation Vertucci found second premolar had one canal, apex is 97.5 of the study, and canals, 2 canals was 3.5. Regarding the 3 canals, most of the study reported it is from 0 to 0.5. Another also, there is a cases reported for second premolar with the 3 canals is a deep and Rogge and Holzman, and 4 canals was described as a Fozan and Barm and Flesching. It is important also that careful evaluation of each radiograph taken before the treatment and during the treatment is very important to get the success root canal treatment. Root canal not be evidence in the radiograph and may look unusual. Any sudden changing in the radiograph, you have to suspect that there is any extra canal. We have to put caution that during clinical examination or during the access cavity or during the canal, looking for it, we have to suspect that there is another canal that could be there. Also, it is important that we have to angle the radiograph to find the extra canal. It is essential, providing insighting into the number of existing root canal. Slowly in 1974, discussed the fact of these extra canal accounted for many of the endodontics failure, and the most of these extra canal could be found if the clinician was alert to the clues that suggested their presence. Also nowadays, with all this new technology as magnified use, fiber optic illumination for observation of anatomical landmarks in the bulb chamber may be helpful in location additional canal. For better visualization, we use surgical operating microscope that my colleague, Dr. Mandura, he'll explain more about the benefit of using microscope in endodontics. As you can see, I hope it will be explained more to you. Conclusion. Also, the knowledge of root canal anatomy and its variation, careful interpretation, and pre-apical radiographs, close clinical inspection of the floor of the bulb chamber, and proper modification of access opening, along with adequate magnification, all are essential for get a successful treatment outcome. Always, the key of success is the knowledge. And thank you. Any question further for this case? Please.
Thank you for a very nice and instructive lecture. It is open to questions, please.
I know after the lunch most of you are sleeping, but I hope you get my point in this case.
Are you familiar with the PIPS laser technique for cleaning out endos? Are you familiar with the PIPS technique for cleaning out endos? PIPS, P-I-P-S.
For in laser?
Right, yes.
The laser, it is always go in a straight way. isn't it?
No, this is different because what it uses is a sonic vibration going inside the tooth
Yeah.
with your sodium hypochlorite in there.
Yeah. I use the hypochlorite. What you meaning about this?
The laser gives it a sonic blasting into the tooth,
Yeah.
and it's very, very, very excellent for helping to clean them out.
Yes, I will hope this. I will use next time. Thank you.